So a couple groupings. Dr. Papolos, there were a number of questions about FOH appearing outside of bipolar disorder. So this question of, is it simply a phenotype of bipolar, or might there be something else going on in there? And just to give you a sense of those, there was a question around autism in children and teens, schizoaffective disorder, bipolar type. Does sleep apnea come into play with this? So a lot of different thinking around how global is this condition? Is it restricted to bipolar disorder?
Well, first, I mean, in terms of objective evidence, the way we went about, we started the research on this was we were looking to find homogeneous phenotypes in bipolar disorder. And so we had gotten the clinical data that we originally got from really thousands of people over a period of years was basically people who had been diagnosed in the community with bipolar disorder, or who came from enriched family with an enriched family history. So the research that we've done in identifying this phenomena in bipolar disorder is, I would say, doesn't allow us to look in a more general way at a general population of other diagnoses, and those are things that need to be done. I can tell you that there, and again, when we talk about these diagnoses, that people are saying autism and and often OCD comes up. I mean, the question is, these are DSM diagnoses. These are categorical diagnoses that were established by consensus. Nobody asked anybody about temperature dysregulation. As long as you met the criteria that were in the book, you met the criteria. Now, as I said at the beginning, this is a pleomorphic condition. Many OCD symptoms are present, and autistic symptoms, I would say, that are part of the autistic spectrum. So, and we do believe that particularly within the autistic spectrum conditions, that a sizable percentage probably present with thermoregulatory problems and also these fear of harm symptoms. So and that's my own clinical observation.
Thank you, Dr. Papolos. And one other piece you commented on the end that Anne Reed just asked us a question is, what are the updates on getting this included in the DSM? What's happening? What's the process? I know that's a very complicated question to ask at the end of this session, but it's also a really important one.
Yes, well, the last major thing we had was a workshop at the Harvard Radcliffe Accelerator Conference. I guess it was maybe 2 years ago. And we had clinicians and people who were involved in DSM who came, and it was a 2-day basically presentation of I think it was 2 days of what the findings have been, and we were asking for essentially their expert opinion about how to go about getting this into the DSM, and one of the major things was to really begin to get more publications in the literature before petitioning and to do more research, both of which we have been trying to do. I would say we've getting something about this condition published has not been easy at this point. And why that is, I leave to your own speculation. But hopefully we have a paper that essentially describes in detail, that reviews the literature on childhood onset bipolar disorder. What have been the studies that have been done in terms of treatment, and they're basically de minimis. The major finding that we were able to find was that family therapy and psychoeducational work was really the most well-supported adjunctive treatment. And then there was really nothing else that that you could hang your hat on. So there's an enormous need for research to be done in this area. And hopefully this is a review paper. We're going to be submitting it, I think, in the next month again. And hopefully it'll be accepted. And it's there have to be a lot of people working on this. Basically, there have to be more people that get interested in it and begin to do research and begin to demonstrate that it's a real thing and that there are effective treatments. And even though virtually none of the DSM diagnoses have any basic I guess, scientific evidence to support them as independent diagnoses. Now, for whatever reason, it's hard to get in.
Thank you, Dr. Papolos. And maybe just to add to that, also one of the reasons that the Children's Mental Health Resource Center and Juvenile Bipolar Research Foundations are holding forums like this is so that the conversation becomes more mainstream. And so it's not viewed as some fringe issue, but rather a major component of understanding mental health in children. I'm going to go to a couple more questions. I will let you know that every question that's been posed here has been cataloged. So we will read these over and review those going into the third session, which is an extended question and answer. So if we're not able to speak to your question tonight, please know that we did receive it and we'll try to address it at the next. Dr. Papolos, one of the questions regarding treatment was sort of this linear component of stabilizing the bipolar disorder before treating the fear of harm. Can you speak to why that's important to do?
Well, for one thing, ketamine can be activating in the situation where they're not stable, and you can't tell whether ketamine's working or not for the other symptoms unless you've stabilized the mood disorder first. And that's the primary reason.
Great, thank you. So I'm going to finish just with a couple pieces related to thermoregulation regulation in general. One question was how much this appears generally or localized. So does this appear in one part of the body? Is it all over the body? I did in the chat share what you shared last session about the ears acting as sort of the brain's radiator in some ways, so that's a place where discoloration and heat can turn up. But can you speak to that, how localized versus general the overheating is?
Yeah, again, I mean, I think that's something that's a bit, it's not going to be the same for every child, but they feel hot to the touch. Their cheeks are often flushed. The pinna of the ears, which is in animals, is considered sort of where heat gets dissipated from the brain, and their tips of the ears frequently are beet red, and they are generally overheated. They sweat when even in rather not hot environments, and they have this cold tolerance that is noticeable. I mean, the clinical signs of the thermoregulatory problem are not so subtle. Although there is a spectrum, not, so like anything else in nature, it doesn't, occur exactly the same in every individual.
Great. Let's finish up with one more. If I know there's a lot of people hanging there with us, so I hate to close it off prematurely, but let's finish with sort of diagnostics and the genetic diagnostics in particular. One person asked which genetic labs test for the BDNF gene. Someone else asked how can people get tested for this certain gene and what is it called? Can you speak to that at all?
Yeah, I mean, there are some of the major, companies that are doing genetic testing and providing reports about potential side effects, whether you have this particular genotype, whether you'd be more prone to have, be sensitive to serotonin reuptake inhibitors, or whether you're more prone to have side effects if I mean, there's I think a couple of those labs, I'm not going to mentioned specifically, but I don't think that that's something that's clinically useful at this point. One, it hasn't been established I mean, it's, as I said, this is all speculative and based on, what animal studies were done with ketamine. So it's not going to be a reveal or be diagnostic in any way. So I wouldn't want people going off thinking that.
Okay. Well, I would suggest we do wrap up at this point just because of the time. We're up to 50 questions now, and I'm so grateful for that. We will catalog for the next session. I do want to share two things as sort of previews that came up in those. So one was a really interesting question around, so with climate change, what does that mean? And let's hold that, but it's a fascinating question because the environment is changing around us, and that would be great to come back to. Our last question actually said, what about vagus nerve stimulation? Is there anything we can do there? JBRF has just done a study with the Milken Foundation around that, and we'd be very happy to share those thoughts when we're together for the next session. Elizabeth?
There's one question here, though, that I think I would like to just address really quickly before we go, because it is the Juvenile Bipolar Research Foundation and the Children's Mental Health Research Resource Center. And so there's a question here on, does this continue into adulthood? We talk about children because that is our focus, but Dr. Papolos, can you answer this question? Does this continue into adulthood?
Well, it's a complicated question because, we didn't get really into this, but we believe that this syndrome evolves from obviously this humble beginnings as a thermoregulatory, then sleep problem that produces nightmares and night terrors that are recurrent and that lead to behaviors that relate to fear and avoidance of going to sleep and fear of the dark and fear of intruders and fear sensitization. And all of those things are things that become imbued in the brain essentially over time unless you treat it. So I think one question that has always weighed heavily on me after I saw the effect of ketamine is what if we could, intervene at an early age when children are starting to have these recurrent night terrors and starting to show the thermoregulatory problems. And what if we could just, correct those things? Would you ever develop these behavioral symptoms that occur longitudinally over time and are very much akin to PTSD in my mind? When we talked about this condition, it's traumatizing. So I think that that's an important thing to point out. So again, I mean, we need more research, we need more data. I mean, I can only tell you from, a number of people that have reached, as we talked about the original case, which was like almost 20 years ago now, and how well she's doing. Do you try to, at what point do you try to take someone off the medication? And I do that frequently after there's been stability for a period of time, but there's not enough cases to be able to conclude, to be able to answer that question objectively.
But without treatment, would you see these symptoms presenting in adult patients?
Oh, well, it's not diagnosed. So, right. So you see it, of course you do. I mean, because nobody diagnoses it for the most part. I mean, they typically they're treatment refractory. I mean, another good study would be, to what extent do the cases that are being called treatment refractory depression in adulthood, who respond to ketamine, do they have, fear of harm, and did they have early symptoms? I mean, that would be like a great study to do and might, shed some light on all of this.
Sure would be. Well, I want to thank you, Dr. Papolos, for being with us again, and James for being here too to field all these fantastic questions, which, yes, indeed, are being cataloged. And next time, please be on the lookout in your email boxes, because we will be sending out links to the recordings to everyone who registered. We'll also be sending out additional information about the Q&A sessions in 2 weeks, so that we can make sure that we get the maximum number of people able to ask their questions and get them answered. So thank you all for being with us, and we look forward to seeing you in 2 weeks. Good night, everyone.
Night.
Right.